You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 20th, 2019. This week, the polypill, dapagliflozin, TAVR, and the brain-heart connection. Let's first start with the polypill. Two recent studies in The Lancet and New England Journal force a rethinking of the polypill approach to preventing cardiovascular events. First, some important background. Heart disease, along with cancer, are the health challenges of today. Blood pressure control and cholesterol lowering are proven to be effective for prevention. High blood pressure and high cholesterol are common in people with lower socioeconomic status, and everyone knows that adherence to medical therapy is difficult, especially among lower income, underserved population. And of course, the less time a patient spends being a patient, the more time there is to live life. Enter the polypill, which combines multiple chemicals in one pill. Now, the advantage is obvious. It's convenience. Common sense holds that therapies that are more convenient are more likely to be used. Think direct-acting oral anticoagulants over warfarin, for instance. But just because something sounds better does not mean that it is better. You know what we need. Evidence. We need evidence. Vanderbilt researchers set out to study a polypill of 4 compounds, amlodipine, losartan, HCTZ, these drugs in very low doses, plus atorvastatin, also in the same pill, versus a usual care group, and they did this in an underserved area of Alabama. About 300 patients with risk factors for heart disease but without heart disease were randomized to the polypill versus standard care. The two primary endpoints were change in blood pressure and LDL cholesterol at 1 year. The trial was conducted at a federally qualified community health center. 96% of patients were Black, 60% women, and the mean estimated cardiovascular 10-year risk was 13%. The polypill group did better. Blood pressure decreased by 9 millimeters versus 2 in the usual care, and LDL dropped by 15 milligrams per deciliter versus 4 in the usual care. Adherence to the polypill group was 86%. Also reassuring was that over half the population randomized to the polypill were already on a blood pressure lowering drug, and they still had lower blood pressures at 1 year. There were no safety issues reported. Now, missing data was an issue. 20 patients discontinued a trial in the polypill group versus 8 in the usual care. The authors did some imputed analysis that upheld the main results. But the authors themselves also noted the open-label nature of the study. They did this to preserve the flexibility to titrate medicines and also to simulate the real-world use of the polypill. But to me, the Hawthorne effect, that is doing better because you are being studied, would affect both groups equally, as this was conducted in one community health center in Alabama. The polypill was also free, whereas the usual care group had co-payments, albeit low, but we all know that any kind of payment may decrease compliance. Now, before I comment on this study, let me also point you to another polypill study. Now, this was the Poly-Iran study, which was published in The Lancet. This was a cluster randomized trial of about 6,800 adults in which villages were randomized to either a package of non-pharmacologic preventive interventions alone, this was the minimal care group, or together with a once-daily polypill tablet. And the randomization was stratified by 3 districts with the village as the unit of randomization. In this case, the polypill included hydrochlorothiazide, aspirin, atorvastatin, and enalapril. Participants who developed a cough were switched to the polypill, which included valsartan 40 milligrams instead of enalapril. During a 5-year follow-up, about 3% fewer people in the polypill group had a major adverse cardiac event, 5.9 versus 8.8%. Here are some comments on these studies and the polypill in general. The simplicity factor of this polypill made me think of Victor Montori, an endocrinologist from the Mayo Clinic, known for his work on shared decision-making and minimally disruptive medicine. He's also very kind and generous, and we spoke on the phone last night, and he helped me understand the polypill. His main point was to distinguish public health from clinical medicine. When the polypill was first proposed, it was thought of as a public health intervention. For instance, we had to get people taking this pill so as to improve societal or public health. This, he said, is not the right way to think of public health. He explained that public health is ecological and people consume it without knowing it, say clean air and clean water. Public health should not be confused with clinical medicine, in which we treat individuals, not populations. Well, public health is also low risk. There's no harm from breathing cleaner air and water or having walkable neighborhoods. Giving people chemicals is clinical medicine, and it's certainly riskier than most public health interventions. Montori thought that the recent studies of the polypill show a shift in framing of the polypill as a clinical intervention. This, he felt, has merit. The polypill is simple, minimally disruptive, and it's especially helpful for higher risk and underserved patients. Now, even before talking to Montori, my mind was changing on the polypill. As a younger doctor, I worried about the interaction of all these drugs, the inability to titrate or sort out a certain side effect. The, quote, right way to practice medicine in my idealistic mind was to see your patients frequently and precisely titrate medications. Well, then I started helping out in an underserved clinic that my partner started. It's called the Have a Heart Clinic, and it's an eye-opener. You see the discrepancy of U.S. healthcare firsthand, and it changes your mind. During the week at my regular job in electrophysiology, I work in a sea of overdiagnosis and overtreatment. But when I volunteer at the Have a Heart Clinic, I see the ravages of undertreatment. While wealthy Americans with health insurance incur the dangers of overzealous fee-for-service care, poor people in this nation incur the dangers of not getting basic care like blood pressure and cholesterol-lowering medicines. A polypill may offer huge numbers of people a modicum of CV prevention. These studies are far from perfect, but they are a start. And as Montori noted, they study the polypill from a clinical frame, and this is good. The minimally disruptive frame represents another change that I've undergone as an older person. Again, my idealistic younger mind discounted the time and energy spent going to the doctor, the travel, the parking, the wait times, the demeaning filling out of forms. My older self now sees the elegance in medical care that minimizes the disruption to people's lives. And for this, I thank Dr. Victor Montori from the Mayo Clinic. Second topic today is the DAPA heart failure trial is now published. 3 weeks ago, I reported the positive results of DAPA-HF. This was an RCT in patients with heart failure with reduced ejection fraction that found dapagliflozin reduced heart failure outcomes or CV death. At the time the trial was not published. That has changed. New England Journal published it along with an excellent editorial from Dr. James Fang at the University of Utah. Now, I didn't find any significant changes from the data presented at ESC and the paper, but from the presentation, we knew the relative risk reductions was about 26% for the primary endpoint. But in the paper, we now have Table 2, and that shows that the absolute risk reduction with DAPA was 4.9%, which corresponds to an NNT of 20. Now, also notable this week was another dapagliflozin trial called DEFINE-HF. This was presented at the Heart Failure Society sessions in Philadelphia, and it was also published in Circulation. DEFINE-HF was a smaller trial, about 260 patients with heart failure with reduced ejection fraction, similar to DAPA-HF, with about 40% of them non-diabetics. And here investigators compared the drug DAPA versus placebo, and they looked at two primary endpoints. The first was simply NT-proBNP levels, and the second was the proportion of patients with a greater than 5-point increase in the Kansas City Cardiomyopathy Questionnaire, or KCCQ, or a greater than 20% decrease in NT-proBNP. Now, over 6 to 12-week follow-up, there were no differences in the NT-proBNP levels, but 10% more DAPA-treated patients met the second co-primary endpoint versus placebo. This was a nominally significant difference, and it was driven by improved quality of life on the KCCQ questionnaire. Now, I've been talking up the SGLT2 inhibitors at my hospital, and I've been surprised at the lack of excitement and also the skepticism. I'm like, y'all, DAPA improved hard outcomes in a blinded trial in patients already on background therapy. It doesn't matter if you don't know how the drug works. But my colleagues are pragmatic clinicians that work on the front lines. They don't do trials in well-selected patients. They struggle with things like poor drug adherence or treating elderly, frail patients with multimorbidity, or even the mundane but maddening task of doing pre-authorizations for new and expensive drugs. The editorialist, Dr. Fang, discussed these headwinds for translating this evidence at the bedside. Using these drugs is going to be complicated. Robots will never be able to practice heart failure care. And treating heart failure with reduced ejection fraction patients these days will require lots of clinical skills, and thank goodness for that. I stand by my prediction that SGLT2 inhibitors represent a big advance in cardiovascular medicine. DAPA-HF yielded consistently strong results, and previous trials with this class showed similar results in diabetics. I suspect that many upcoming trials will confirm the findings of DAPA-HF. Third topic today is reducing pacemakers after TAVR. Now, the risk of causing heart block after a TAVR procedure was less of a big deal when these procedures were done in high-risk, older, sicker patients. But it's a much bigger deal when doing TAVR in younger patients. Here, the downsides of pacer dependence loom larger. Briefly, the risks of a pacemaker include the surgical risk, the short and long-term risks of infection, the risk of dysynchronous ventricular contraction when non-his bundle pacing is performed. There's the death from possible lead failures and the need for multiple generator changes, which have higher complication rates than de novo implants. And that's why I was drawn to an interesting single-center study published in JACC Interventions looking at a TAVR technique that, quote, respects an individualized anatomy and uses a precision procedural technique that dramatically reduced the need for pacemakers. Investigators at New York University Langone presented a two-part study. The first part retrospectively analyzed anatomic and patient characteristics, specifically the depth of the membranous septum. The membranous septum is the home of the His bundle, and the depth of the TAVR valve placement. They then used this retrospective data to prospectively test this MIDAS procedure. MIDAS stands for minimizing depth according to the membranous septum approach in 100 patients. And when they used this individualized technique, they were able to lower new permanent pacer rate from 9.7% in the standard cohort to 3% in the prospective cohort. Also, the rate of new left bundle branch block after the procedure fell from 25.8% to 9%. These are remarkable findings because this series included Medtronic self-expanding valves, and in the recent low-risk trial with these valves, the rate of pacing was a whopping 17%. So I highlight this study on clinical grounds, but also because it shows the value of iteration of procedures. I show my age when I say I used to place coronary sinus leads for Bivi implants when there was only one lead and one sheath. It's long been known that the length of the membranous septum is inversely related to the risk of AV block after the TAVR procedure. Shorter septums means more AV block. What the group from New York University Langone did was measure the membranous septum and try to implant the valve at a depth as measured at the level of the non-coronary cusp less than the membranous septum length. JACC Interventions summoned an excellent editorial from Dr. Rose Cabal, who lauded the study, noting that these were very positive findings and it challenges the notion of a class effect of valve type and pacemaker risk. Perhaps the self-expander valves can be done without having high pacer rates. But he also noted the preliminary nature of these single-center findings. For instance, can the membranous septum be reliably measured? Can these results be replicated in other centers or multi-site trials? And will the Midas technique result in higher rates of valve recapture and repositioning, which may increase the risk of embolic events? I think we should remain skeptical, but also this study highlights the value of iterative progress in procedures. Another topic today is video gaming and arrhythmias. Case reports sit way below RCTs on the ladder of evidence, but still, cases can teach you a lot. The New England Journal published a brief report of malignant ventricular arrhythmias in children playing video games. In refreshingly brief and clear language, Australian authors described 3 cases of VTVF that occurred during moments of peak excitement during these video war games. The 2 newly diagnosed cases were a 10-year-old with catecholaminergic polymorphic ventricular tachycardia, which is an abnormality of the gene coding for the rhinanidine receptor 2, and the other case was an 11-year-old with long QT syndrome. The third case was a 15-year-old with previous heart surgery for detransposition who had sustained monomorphic VT. Now, of course, I'm not highlighting this series, and the New England Journal is not publishing it to make the case that video games are dangerous. Surely there are more dangerous activities for children, say being carted around in an automobile, for instance. My friend and colleague, Professor Shiv Kumar from UCLA, had it right in a tweet. He wrote, quote, "Here is yet another remarkable, albeit scary, example of the powerful link between the brain and the heart. Neurocardiology in clinical practice, the mind matters a lot," end quote. My take is that many clinicians and really mainstream medicine underappreciates the brain-heart link. Electrophysiology doctors see this often, and we see acute stresses associated with an appropriate ICD shock. What about atrial fibrillation flare-ups during grieving periods or PVCs during periods of work stress? Then there is Takotsubo phenomenon, in which a stressful or even joyous event can cause an acute loss of anterior apical contraction and an MI-like picture. Gosh, this is a curious condition. So here is another prediction. Future generations will look back on our understanding of the neural connections of the heart as extremely limited. We have a lot to learn about neurocardiology. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please tell a friend, subscribe, or give us a rating on whatever app you use. It helps other people find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.